thank you to Julio and the organizers of this meeting for the opportunity to speak today. So I'm going to try to give a little bit of a perspective on the remaining parts of the research agenda and where I think the research agenda can go in the area of treatment and treatment as prevention. But at first, I think it's also important to think about where we have been. And we heard about tipping points last night in terms of Eric talking about the populations that have an R0, an R0 of under 1. But in many ways, this paper was our tipping point. I mean, there was a fair amount going on in treatment as prevention, but Ruben's paper with Kevin and Brian really, in many ways, became a nucleating event for us as a field. As we all have read this paper and debated it endlessly since 2008, it really was a model of what could be done, and in many ways was very aspirational. Not wanting to be left behind, Tony and I jumped into the game with our own version of the research issues, and in many ways, some of these remain important questions that still need to be addressed. How do we get to universal testing? What is the relationship between stage of infection and efficiency? I mean, we haven't really at this meeting yet delved into the role of acute infection. That remains an outstanding question that the field needs to grapple with. The way we tend to think about it is, well, the approach for that may be expanded repeat testing, but that then just cycles back between these two and creates, in some ways, possibly a futile loop that is problematic. 052 clearly demonstrated the efficacy of preventing infection. We need to deal with drug resistance, behavioral disinhibition, benefit to the individual of early treatment, and cost effectiveness to society. But in thinking about this, as I was preparing this talk, there are a couple of gaps that have emerged in the research agenda, and one of the ones we talked about last night was the holistic approach. How do we, it's not just about getting the pallets of drugs into country, it's how do we deliver the drugs, how do we engage people in care, how do we retain them in care in a way that is efficient, effective, and useful to the individual, and making the individual feel they're part of the process in an ethical and caring kind of way. The National HIV/AIDS strategy has also come along in the intervening time, and for those in the federal government of the United States that worked on this, this really is about, this was a theme last night, is put your resources where they're going to matter the most. With a goal of reducing incidence, increase access to care, reducing health disparities, and then linkage of federal partners. But ultimately, it is about targeting your resources where they can have the greatest need. Now, none of these are research questions, but there are research activities that are embedded in this to evaluate the implementation of these types of programs. The NIH got involved with the HPTN in a test and treat like protocol, TLC plus, that is actually reaching nearing the final lap this year in the Bronx and Washington, D.C. to look at improved ways of testing, better ways of linkage to care, as well as asking some questions of both patients and providers about how they're viewing the implementation of such a program. In some ways, this is sort of the dinosaur, because it was one of the first out of the box, and in many ways the studies that have come along since have supplanted and surpassed what 065 is doing. However, I think we'll still get some very useful data out of 065 that will help inform what we are doing both domestically and internationally. I only show this slide because I think this is another one of those tipping points for our field, and it's not just the fact that the paper was published in 2011, but it was also recognized as such an important event. But the reason I use this slide is to remind me of two things. It wasn't just about delivery of drugs. It was delivery of medication combined with an effective treatment intervention strategy that allowed the HPTN 052 team to fully get the maximum amount of viral suppression in the populations that were being treated. That's the first message. And the second message is the innovation. And the innovation was molecular phylogeny, the ability to track the origin of the infections and to say in a fairly definitive way, this infection came from within the discordant couple or came from outside the discordant couple. And I think as we move forward, applying molecular phylogeny in studies is going to be a very important tool for us to really understand the first rule of prevention, which is know your epidemic. We need to understand where the virus is coming from, and I have an example of that on a later slide. We should all get $1 for every time we see a cascade at this meeting. We have decided at NIH to adopt the CDC version of the cascade. We think this is a much better version than the stepwise model, where the goal, of course, is to eliminate the pyramid, so it's as wide at the top as it is at the bottom. And John, I guess that's your full-time job now, is making that happen for the United States. But you know, the cascade is getting a little better. We heard from Mopoli last night about how San Francisco is up and improved these numbers all the way down, and there are lessons learned, not just from San Francisco, but other jurisdictions about what we can be doing better. So we've had some successes, and they're listed here, and we heard about the countries from Eric last night. But there are some concerns as we move forward, not just in treatment as prevention, but in prevention as general. We still are struggling with how to identify those people who are unaware of their HIV infection. How do we link them into care? How do we treat, and how do we retain? We need to do a better job at demand creation for services. Circumcision is probably the hardest thing to create demand for, but in terms of can we come up with a set of metrics and ways to create demand for testing, for linkage to care, and make it so that it becomes something that people are truly seeking. It enhance health-seeking behaviors. We've learned the hard way that PrEP is an acutely adherence-sensitive intervention. For those of you that try to take multivitamins on a daily basis, if you're like me, it's maybe 3 times a week. That, according to Bob Grant, that may be enough for PrEP. But this is really a problem. And you know, the role of PrEP in prevention remains to be defined if there is a population that is capable of adhering. And also, last night we heard about the need for a holistic approach. We need to be able to have integrated services, including behavioral, social, and structural interventions that really enhance the engagement of care, that we can effectively do better dealing with the comorbidities of psychiatric illness, drug abuse, alcohol abuse, stigma, and encouraging and supporting more than just adherence, but ultimately it comes down to adherence, adherence, and adherence. And so it's a little like real estate. There's 3 things. So in terms of ongoing challenges, as we go forward, we think about test and treat. We think about what we're trying to do, and we think about the epidemic of a population or a region we're dealing with. But I think knowing the source of the infection and where those infections are coming from has to be part of that. And this abstract was at Croy, and it actually was a little bit disconcerting because this is the rural Rakai area, and the Rakai Health Sciences program with David, Tom, and Ron Gray and Maria Waver had been looking at where the source of the infections in the region. They have a high level of coverage with ARTs, but a significant percentage of the infections are coming from people outside of Rakai who are coming in, from truck drivers and from people who are, as they were passing through. So whether it's the new kid on the block who's cute and attractive and everybody wants to party with, we can laugh about that, but at the end of the day, it's not just, it may not be just enough to treat the people in your population, because you can't, what are you giving the negative people? This is where treatment as prevention may need to be a little bit broader, because can we treat everybody in the world? And I think that is one of the things we're struggling with. So this is where I think the intervention and the innovation of molecular phylogeny will help us to understand this aspect of the disease transmission process. In terms of future directions, we must continue to build toward a significantly more integrated behavioral and biomedical approach. In the future, biomedical interventions must begin with behavioral consultations. You cannot sit in a laboratory and design an intervention and then roll it out, and then ask the behaviorists to jerry-rig it to your population. It has to be a true integrated approach from day one. We must be able to use molecular phylogeny for all its power, and that includes knowing how many viruses are actually transmitted in the case of an infection, because that tells us something about the health of the individual, as well as understanding the source of the virus, both from within and outside of villages. We also need to innovate on improved therapies. We need to work on long-acting formulations. We need to get to a situation where, in an ideal world, we're not just one pill once a day with fixed-dose combinations, but can we get to a fixed-dose combination that is delivered monthly or 4 times a year? That should be our aspirational goal as a field. And ultimately, there are a series of PEPFAR, NIH, CDC, World Bank supported implementation studies that will help to define where our successes have been with what we have today, and then define the questions that we need to tackle for the future. So, as Secretary Clinton said at NIH in November of 2011, we have the tools to begin to talk about an AIDS-free generation. But in my mind, it's too early for a victory lap. We need to start down the road of moving toward an AIDS-free generation, but know that there's much more to be done, not just on the research, but on the implementation science side. So thank you.
Thank you, Carl. And we'll move right on to the next